Hello, good afternoon from Toronto. This is Arifa Muzaffar, and I do have Dr. Anthony Leeds from UK. I believe it's evening in UK. What a beautiful age where we live. This is technology. I am here in Toronto and Dr. Leeds is in UK, but we are talking about an issue which is an international and a global issue. Dr. Leeds says it's epidemic, and I think every country has this issue. Dr. Leeds, a visiting professor in the Faculty of Science, University of Copenhagen. The most important, he is doing very many research work, and the most important thing is his current research interests concern the use of low energy diet and a very low energy diets in a weight management in a clinical practice. Dr. Anthony Leeds, I welcome you to the show. And how are you today?
I'm fine, thank you very much indeed. Yeah.
You're a happy, healthy man.
I hope so. Yes, I think so. Yes.
You are. So, today's topic is, of course, obesity, but things revolving around obesity, many problems caused by obesity. We did discuss diabetes in our previous program, but in this program, we are especially going to talk about osteoarthritis. Dr. Leeds, would you mind to tell us something? You said that this is only England's problem, and I believe I live in North America. It's very common here. Obesity is a big issue. Even when I think about Pakistan or anywhere in the world, I see it's a big issue now. Mm-hmm. So, you tell us something about it.
Well, as we've discussed before, people who are overweight and obese have other problems associated with it. And today we're going to talk about osteoarthritis, which is a very common arthritis. It affects older people, particularly in all countries of the world. It may well affect, say, 25% of older men and women, although it tends to affect women more than men. And there's no doubt it is related to being heavy. The load-bearing joints, the knees and hips, are affected more than others. But nevertheless, there is an inflammation element in the condition as well. And what we see is that the small joints of the hands, the joints of the neck, can also be affected. It can be debilitating, and indeed it can cause some individuals to be unable to work as they would wish. And it also causes people to be unable to undertake their household tasks. And so people become in need of some help. And indeed, towards the end, perhaps before the final definitive treatment, which is, of course, to have some joints replaced, people may well be considerably disabled and housebound and unable to do the things that make life worth living. And indeed, there's an association with depression. Also, there's a problem associated with sleep, because when the pain in the joints is very severe, sleep becomes more difficult, and disturbed sleep, of course, can also lead people towards being somewhat depressed.
Dr. Anthony, of course, in our previous program, we did talk about how we can control our weight and what are the precautionary measures we should take. That was in the previous program. And we did talk about diabetes as well. So this program, one thing, Dr. Leeds, you said that this osteoarthritis affects women more than men. Is there any specific reason for that, hormones or what?
I think it's the way in which we know there are genetic factors and familial factors, and I think it's the way that those are actually expressed. It's also important to remember that there's an occupational factor as well, that both men and women who undertake work which involves heavier loads, so men who are lifting, women who are lifting, and then women who are doing work that might, or men indeed, tailors, for example, who may get a lot of joint wear on the joint at the base of the thumb, may well find that they have pain and swelling at that joint. So I think it's sort of linked to the way that genetic factors and occupational factors are played out.
So As you said, Dr. Leeds, what are the symptoms where somebody can have an idea that he's having this osteoarthritis problem?
Pain and stiffness in the joints, and I think the surveys show that the very first symptom that appears is pain in the knees on walking upstairs. And of course, this can occur many, many years before other symptoms and problems develop. Pain and stiffness. The stiffness tends only to last for a relatively short period of time. The knees and hips are the main weight-bearing joints that are affected, and then, of course, the back pain and the small joints of the hands. Shoulders can be affected, and also the neck, but it's the hips and knees that are affected most. And of course, the way we approach this is, first of all, lifestyle management, in that we know that weight is a risk factor, and we know that helping people to lose weight does improve them. And if they can lose enough weight, and the figure is somewhere between 5 and 10% of body weight, so if somebody weighs 90 or 100 kilograms, maybe losing 5 to 7 kilograms, so that would be about 1 stone in imperial measures. If they can lose that much weight, there is good evidence that the pain will be reduced. We know that while we describe this as a wear and tear arthritis, there is actually a degree of inflammation in the tissues around the joint, so the membrane and some of the other tissue near to the joint is inflamed, and that losing weight does tend to switch off the inflammation. There's very good recent evidence showing that the markers in the blood, the signals that move around in the blood to cause inflammation and pain, actually go down when there is a sufficient weight reduction. So in terms of lifestyle intervention, it is weight reduction. That's a core feature of lifestyle management, but also making sure that there's sufficient exercise. Now, there may be a tendency when the joint is painful to rest and not use it, but in actual fact, in osteoarthritis, the best thing to do is to strengthen the muscles around the joint and to actually exercise as much as is bearable. And indeed, if you look through the guidance that is given, if there is a degree of increase in pain on exercise, there's a suggestion that mild analgesia, that's pain-killing drugs, might be used before taking that exercise. So the indications are that weight loss and exercise are helpful. In terms of knee support, for example, some people benefit from having, for example, insoles in the shoes, and a combination of all of those things together is probably the best thing that we can do in the first instance. Now, I also mentioned pain-killing drugs, and the physician who's helping to manage the patient has a hierarchy of different drugs. They use mild ones to begin with, and then can move through a series of different levels to the more potent drug-killing medications. And then, of course, ultimately, when the joint is sufficiently bad enough and is damaged enough, it may be necessary to consider a replacement, in which case the individual would then be referred to an orthopedic surgeon for a total or partial knee replacement, and if it's the hips that are affected, then for a hip replacement. However, prior to that stage, the individual will have passed through a period of 15, maybe 20 or even 25 years of increasingly severe pain. And so there are an awful lot of people worldwide who suffer from and accept the level of disability and pain, and perhaps worldwide we're not as aggressive as we should be about helping people before they get to the point where they need surgery. And this is an area which is being addressed both in Copenhagen in the Parker Institute, where I work, and also in some centres in the United Kingdom, where we're looking at what we can do to help people before they get to the point of needing surgery. Now, in some very large clinical trials that we've done in Copenhagen, we have worked through them in proper randomized design trials to determine the effect of different ways of losing weight. And we've been using formula diet products to achieve enough weight loss to get the reduction of pain, the improvement in the questionnaire results on the quality of life, and also to improve their mobility and their ability to get out and about. And the participants in that trial to whom I've spoken have said that some of them been able to get back on their bicycles and cycle around Copenhagen, and others say that they're able to play with their grandchildren on the floor and then get up again off the floor, because one of the findings of those who have this condition is that their ability to bend down, to look into low level cupboards, if they kneel down on the floor to play with grandchildren, they can't get up again. And these are really quite disabling issues. Also, we have to bear in mind that there are important roles for older people as carers for young children when their parents are out of work. So there is inevitably consequences to having this condition. It's a major impairment of ability. People sometimes have to stop work early because of this condition. So we should be better at managing it. A lot of work is being done. Many countries have some very good centres. In Canada, there are good centres, and there are also specialist centres in India and Pakistan as well, and in the UK, of course.
Thank you very much. So this is what I understood. Everything is revolving around lifestyle management, food and weight loss. But there are people like me, I know this is a question from nowhere. As you said that it is genetically transmitted as well, or heredity as well. So many people think that it's a heredity issue. They don't take the precautionary measures. What do you suggest to them? Because a person like me would think, okay, my mama had it, so I have to have it. So can I avoid it?
Well, the family history and the genetic factors can't be changed. There are different patterns that occur in families, that some people, their knees may be more affected, whereas some people, their hips and knees might be affected, and they may well have hand arthritis. Not everybody has hand arthritis. And gradually, as the years go by, we're getting to understand a little bit more about the differences between these different types of arthritis. So my answer to your question would be that it is not necessary for an individual to necessarily follow the pathway that, say, an aunt or their parent actually followed, if they are aggressive enough about addressing the lifestyle measures. Now, globally, we are seeing aging populations, and we are also seeing increasing numbers of people who are overweight and obese. We also have the very good evidence that weight reduction, it's a greater weight loss than might be normally achieved with conventional diet, but maybe something of the order of 7.5, 10% weight loss. In the Copenhagen trial that I just described for you, we achieved initially 12% weight loss, and they maintained 10% weight loss for up to 4, which is a very, very good result. There's another aspect I should also mention, and that is with conventional diet. Conventional diet is a good way of losing weight, but imagine if you're in pain and you are not able to sleep well at night because of your pain, and then you place yourself on a reducing diet which restricts your intake of various foods that you perhaps like. It's very, very difficult to be motivated under those circumstances, and that is why we use this particular method of formula diets in Copenhagen, and why we've demonstrated, and it's all fully published now, to show that it is a way of achieving weight loss in a that is otherwise quite difficult to help as far as weight loss is concerned. Now, this type of intervention is not rolled out worldwide yet. It still has to be considered and incorporated into guidelines, but the evidence is there. And it's sufficient that other places are beginning to look at this as a way of intervention. However, we would never say it's just a question of diet. First of all, there's the question that if you lose weight, you've got to maintain it. We've been looking at different ways of helping people to maintain weight after they've lost it. But also, you have to educate people about the changes that they need to make in their lifestyle with regard to maintaining the weight, the choices they have to make, and so on. But as far as the osteoarthritis is concerned, it's not just diet on its own. It has to include physical activity. It has to include muscle strengthening exercises, as well as the aerobic exercise achieved by walking about or running. And there, with respect to the types of exercise that are chosen, an individual will be well advised to seek some professional guidance. So certain types of exercise are probably not good ones to do. So, for example, running may not be particularly good if you've got quite bad knee arthritis or hip arthritis, may well indeed not be possible. Cycling may be easier because of the pattern of forces on the knee. Swimming, very good one. Movements in water, exercises in water would be particularly good in relation to strengthening muscles. But then there are also sets of exercises that can be given to people using, for example, elastic bands, special elastic bands. And my recommendation would be that people who are interested in this should go and seek advice from the various sources that are available. Now, at the end of the program, we'll be giving the web links to the arthritis associations in Canada and India and Pakistan and the UK, and I've given the links there to the pages on the osteoarthritis guidance. But then, of course, each individual would be well advised to seek guidance from their own physician, and if they need dietary guidance, then they can seek guidance from the physician and dietitian, and of course, attending a physiotherapist to get a specific set of exercises for the particular pattern of osteoarthritis that they have would be very important.
I was reading one of your statement in, as you said before, I think it was 10 years ago you gave this interview, and according to that statement, GPs in the primary care struggle to offer effective solution. This means people, whatever they are advised, they have to stick to that advice seriously to lose weight so that they can avoid other problems. Only doctors cannot make the difference. People, they have to play their role as well. Now, you did talk about some medicine for the arthritis. Any other treatment? Because a person like myself, I always think I'm having a pain. We put, what is that, Vintagina, or there are some balms what we put on, and it gives us temporary relief. So what other treatments would you recommend?
Well, in terms of over-the-counter treatments, of course, then the sort of lower, milder levels of pain-killing drugs, paracetamol, and then also topical gels like the ibuprofen, non-steroidal anti-inflammatory drugs can be applied. They can be purchased over the counter. When you then go to prescribable medications, then of course it's necessary to consult the general practitioner or general physician or a rheumatologist who will guide the individual through the different levels. And of course, the more potent pain-killing drugs are only available on prescription. So in terms of self-management, it's over-the-counter analgesic pain-killing drugs and the topical gels, which are very, very effective actually, and appropriately applied, can make the joint pain very much better. But this is we have to remember this is a progressive condition. It's a consequence of wear and tear on the joint, therefore it's inevitable that the older you get, the more likely you are to have it. It's also a consequence of the way in which the joint tries to repair itself. So there are natural processes in the joint which do aim to, they actually can achieve some degree of joint repair, but when those two processes are out of kilter and the wear and tear exceeds the effect of the repair process, then the features of the osteoarthritis will appear. And of course, with the osteoarthritis, there is the pain. And the pain is the most distressing feature of the condition. It's the pain that really does cause deterioration of quality of life, although obviously immobility and indeed an inability to actually complete one's employment tasks, for example, would be a serious problem.
So what I understood is that, as you said, that repair within the body or muscles, this means if somebody has this issue, he should not exert those muscles so the inflammation can be out of control. Is that what you mean?
No, the natural processes are there's a repair process and there is the disease process. And in an ideal world, of course, the repair process will be totally effective and you wouldn't get osteoarthritis as you age. In practice, we know that quite a proportion, maybe 15-18% of people over the age of 50, over the age of 65, have the condition, and it's an aging process. But it's an aging process that can be ameliorated by the lifestyle interventions that we've just spoken of. With regard to muscle function, what happens, of course, is that if the pain is severe and an individual chooses to be immobile rather than to be more active, then the reduction in the mass or weight of the muscle will occur. In other words, muscle atrophy. And many people who have osteoarthritis, if they look at, for example, the muscles around the knee, you would find that they will not be as bulky as they should be because they've not actually been using the joint as much as possible. And in surveys of the total amount of muscle, in the bodies of people with osteoarthritis do show that these tend to be lower, which tells us that the natural behavioral response to this condition is for people to do less activity rather than more, whereas what we know is that what they should be doing is, what ideally they should be doing, is more physical activity under two headings. One, increasing the strength of muscles, and so that does mean specific strengthening exercises, and people really need to find out about those in detail or to be guided by a physiotherapist, and then also aerobic exercise as well. So walking, simply walking, running in the milder cases, but one has to be careful about not doing too much running. Swimming, an exercise, excellent exercise for people with osteoarthritis.
So this means if somebody wants to help themselves to cure this problem, so these are the remedies.
Yes, those are the ideal ones, but I do advise people to seek more detailed guidance. Everything that I'm saying is generalized, and nobody should take any action based on this sort of very general statement. They should look at the specific sources of information on their own websites. The links will be given later, and they should always, of course, seek expert professional guidance from their general practitioner, from a dietitian with regards to diet, and also a physiotherapist with regard to the exercise routines that they should follow. Or on some of the websites that I'm giving links to, there are some videos which A, give information about osteoarthritis, and then also B, there are videos about the exercises. So there's a lot of extremely good material that is now available for people to look up themselves.
Would you mind to share some of these guidelines, how they can help themselves?
Yes, well, we've given the links. So what individuals will find, for example, if you go on the Arthritis Canada website, you'll find pages that describe the condition, the causes, the ways in which those things that can be changed, like weight and physical activity, how to do that. The types of diet that we've been studying in Copenhagen are not yet generally available, although I have to say the guidelines for the management of obesity in Canada do include one of the options for the formula diet program. So the physician might want to make a recommendation there. The target for weight loss is somewhere between 5 and 10% body weight loss, which means just under a stone or 1.5 stones. Which can seem to be quite a lot and is quite difficult to achieve with conventional diet. But as I have commented before, if there's scope for change and an individual is willing to make a change, then it is possible. However, again, from my own clinical practice, I know that for people with osteoarthritis, actually losing weight really is a challenge. That was why we did those trials in Copenhagen starting in 2007, and that we're obviously very pleased that we've been able to demonstrate that people with this condition are able to lose 10 to 12% of body weight with a total diet replacement formula diet and can actually maintain that weight for up to 4 years. They don't, of course, have to follow the special diet for a long period of time. They do the special diet, lose the weight, and then go on to a maintenance program based on either conventional diet, having passed through quite detailed educational programs with the dietitian to learn about what changes they have to make, and that then takes us back to all the things we talked about before, like issues of portion size, the type of foods chosen, the quality of the diet, when to eat and when not to eat, foods to avoid, the very high energy density foods to avoid, and so on, all of which are the things that need to be changed in the longer term. And we have, however, produced 4-year maintenance results, we're very, very pleased with those. And other countries are now looking at those with the possibility to considering whether or not they're appropriate for people with osteoarthritis.
Dr. Leeds, thank you very much. So, in the layman's language, that's my language, when you go for the groceries, do not go to those aisles where you get all these drinks. Soft drinks, don't go there. And you said foods to avoid. What are the foods to avoid?
If an individual were to seek guidance from a dietitian, they would first of all find out the pattern of eating and the types of foods consumed. They will look at the family environment. What are the influences on the food choices? How much influence does an individual have over what they themselves consume? A high proportion of food intake is now taken outside the home. How easy is it for an individual to choose an appropriately priced meal out of the home? The less expensive ones perhaps are the ones that contain more energy. Is there food labeling? Now, food labeling and menu labeling are issues. In most countries now we have very good food labeling, so people can, if they're buying their own foods, they can find out exactly what the content will be in terms of energy and fat and sugars and so on. In the restaurant environment or the cafeteria environment, it's more difficult. You can ask the energy content, although sometimes you may get a sort of blank response. We have some newly developed legislation in the UK, which is in the process of being considered at the present time, with regard to a requirement for restaurants to label the menus with the amount of energy. However, as was discussed in the current issue of the British Medical Journal, there's a bit of debate about whether actually doing that will make a real difference. Menu labeling on its own may not be sufficient. It may require other forms of activity. In other words, what this is suggesting is that when we think of the public health context of addressing the issue of overweight and obesity, and it's probably true to say that no country in the world has got a really good way of doing this, although I have to say that places like Finland, who have been looking at issues that relate to the originally high rates for cardiovascular disease there 25, 30, 40 years ago, perhaps Finland has one of the better approaches. Most countries have not fully addressed the pandemic that we now have of obesity. And of course, the present ongoing global pandemic of COVID-19 has emphasized how being overweight and obese and having the metabolic associated conditions that are associated with obesity can actually increase the risk of hospitalization and also of more severe disease. So it may well be that while this viral pandemic has been a very, very severe experience for the entire globe, it may well point to the necessity for being more effective in addressing the global problem of obesity and overweight.
Thank you very much. And today, after talking to you, I think I better go to Finland now.
Yeah. Okay.
Because if I will go to Finland, of course, I won't gain weight, I won't have obesity, I won't be obese, I won't get diabetes, I won't have arthritis, so I'll solve many problems. Dr. Leeds, thank you very kindly, and I believe people must take it serious. You must take it serious.
Yep.
Lose your weight, control, look at how many calories you take. With the age, of course, we don't need more calories, so avoid these things and stay happy, stay healthy, and stay safe. Dr. Leeds, thank you very much for your time.
Thank you. Thank you. Thank you.
God bless you. You're such
Thank
a
you.
wonderful person. Thanks. And viewers, inshallah, we'll meet you in the next program with Dr. Leeds. Till that time, have a great time. Bye-bye.